Good morning, Becca. Welcome to the podcast. I'm super excited to have you on.
Me too.
I'm so excited to learn more about you. Like I mentioned before we started hitting record, like I know you through social media, but this is the first time that we're, I guess not even technically meeting, but meeting, via Zoom. And I follow your work and all the really just cool stuff that you're doing for your patients and just for the field of oral facial myology, for dental hygienists. So I'm super excited for everybody to hear more about you and the way you practice. So let's start, like, if you can just share a little bit of your journey and how your journey from hygiene turned into, and I know you don't, I don't want to, you explain it all. I know you don't call it myofunctional therapy or oral facial myology. You have your own term, but we'll let you explain that.
Thank you for having me on. It's really an honor to be here. So my journey, it's kind of, they always say that people's journeys they're not linear. They're all over the place, right? It's like, where am I going? What am I doing? What's going on? Um, I've been in dentistry since 2009. I started out as a dental assistant. I graduated hygiene school in 2015. Once I got into hygiene, I was like, there's so much more to this. What is going on? I started working with a sleep and TMJ dentist. I learned about myofunctional therapy then. Went and trained in myofunctional therapy in 2017. And then I took another class in 2018, another course where I got my CSOM through a speech therapist. So I took my first one through a hygienist, second one through a speech therapist. And then I launched my practice early on, starting working with babies and kids and doing hybrid and going in home and doing the evaluations and online. And that wasn't really my thing. I'm very kinesthetic. I need to be hands-on. I need to palpate and feel and what's going on here and why isn't this working? Um, and I ended up closing down the practice because my husband was military and we lived out in Oak Harbor. And so I ended up closing down the practice because I couldn't serve those patients anymore. And I'm like, what is my next move? And so I went and worked back in hygiene. And then I myself found my own dysfunctions. And I had three different consults for orthodontists. Each one of them said I needed orthognathic surgery. And so in 2019, I had jaw surgery, double jaw surgery, upper jaw, lower jaw, and chin. Then when time came for after surgery, I couldn't move. I couldn't move for a long time. It was over 6 months that I couldn't open my jaw. The exercises that I used to do as a myofunctional therapist that I had mastered, I couldn't do anymore. My tongue couldn't move in ways that I was used to. I couldn't chew, I couldn't eat. I was absolutely miserable. I lost a ton of weight. I started researching for anybody, physical therapist, massage therapist, because in Washington State, massage therapists can do intraoral massage. And nobody wanted to touch me. And they're like, well, you just had surgery. We don't know what's going on. I'm just like, what? And so that prompted me, after a lot of research, in 2020, right after COVID, I ended up going back to school to be a massage therapist. And from there, I learned lymphatic drainage and intraoral massage. And the more that I got into that, I'm like, why aren't hygienists doing this?
Mm-hmm. Mm-hmm.
We should already be doing this. There's only 7 states across the country that or massage therapists can go intraoral, do intraoral massage. But it's just like this is head and neck. This is
Right.
our realm.
Right.
And so anyway, I was like, I'm going to help people who have had orthodontic surgery
Mm-hmm.
because I don't want anybody to go through what I went through.
And there's such a need.
And
Such a
there's such a need. And so I launched my practice in downtown Seattle. And people I had a lot of people were coming to find me. The referral sources weren't there because the doctors were like, "What are you doing?
mm-hmm.
What's going on? Who you're a massage therapist?" Well, yes, no, I am, but I also have a background in dental hygiene. This is what I do. So I started going backdoor marketing. Patients would find me, and then I would just write them letters. Hey, this is what we're doing. This is what's going on. I'll see them at 6 weeks unless you have any other concerns,
Mm-hmm.
and that really started to take off. But then I started having people come find me who have had oral cancer, part of their jaw removed, part of their tongue removed. They've already been through speech therapy. They couldn't raise their arm. They had lymph nodes removed. They had just these major facial reconstructive surgeries, Lefort, not just Lefort ones, but Lefort two, Lefort threes, full facial reconstructive. And Bell's palsy, trigeminal neuralgia. They're like, there's nobody around here that does this. And so there's again, I was at an impasse. There's so much more to this.
Hmm.
What is going on? And then that's when I realized that there's a complete drop off in post-surgical rehabilitative care. And because my business was so new and it was so niche, integrating myofunctional therapy in general is challenging to try to get people through the door, let alone adding on the manual therapy component
Hmm.
and walking that fine line between massage therapy and myofunctional therapy. Because I do what, as a massage therapist, there's a lot of things that I can't do that I'm doing as a myofunctional therapist.
Hmm.
And so I was like, how can I train more massage therapists to do this? And so I turn it into movement therapy. It's still myofunctional therapy, but it's not for growth guidance and airway.
Hmm.
Right now, myofunctional therapy is all about growth guidance and airway. And it's like there's so much more to this than that. And because the general population that I treat is adults,
Hmm.
and growth guidance and things like that is for kiddos
Hmm.
and moving forward. And when it comes to adults, 95% of my practice was TMJ.
Hmm.
But then the other small percent was these specialty cases. And by the time that these people were coming to find me, it had been 14, 15 years since
Wow.
they had surgery. I'm like, what? So I started doing my research. And the only research that I was finding was coming out of Japan, where the hygienists were in the hospitals, immediately doing these palliative care, rehabilitative care, intensive rehabilitative care for the head, the neck, and the face. Um, and they're starting to come out from India and things like that. But I'm just like, there's nothing in the US. I was like,
Right.
we're supposed to be so far ahead.
Hmm.
What is going on? I'm always asking why. Well, why? Why is it that way? So, yeah, I call it myofunctional therapy because that's what people understand. But I don't call it myofunctional therapy in specific groups because it's not growth guidance and airway, if
Right.
that makes sense. I'm still kind
Yeah.
of trying to fine tune that, but there are more research coming out saying myofunctional therapy with oral cancer, myofunctional therapy. So now I can kind of guide back into reterming it back to
Yep.
myofunctional therapy because the research is there to back it up.
Now, if you can explain, just because some of our listeners are healthcare professionals, some are just parents, families, can you explain lymphatic drainage? Because I know some people listening may not know.
Yeah. So our lymphatic system is our body's plumbing system. If we get a bug bite and that bug bite swells, that is our white blood cells coming up to the surface. It's our immune system trying to combat whatever it is that's there. After surgery, we get really swollen, or if we're running a fever, or if we have an infection, we get really swollen. And that's because the body's trying to fight and heal
Mhm.
all of those those blood cells to get rid of it so we can reduce the inflammation. So that's lymph. In order to move the lymph, we have to manually move it, right? To get it to go into other places. Now, you don't want to do it when there's an infection,
Mhm.
but when there's swelling due to surgery, our lymph system we need to get rid of the dead cells. The only way that the lymphatic system works is by movement. It is manual therapy. It's either you're doing it on your own or you're moving your muscles. The only way the lymphatic system works is by muscular contraction or manual movement. And so, a lot of times when people have surgeries and they're swollen and they're not moving, the last thing that we want to do is move,
Mhm.
right? And we're not doing anything here because it's painful.
Right.
If the lymph sits in a certain area for too long, it can cause scar tissue. And scar tissue that we know restricts movement.
Mhm. Mhm.
So most of the time, if people have some type of major surgery from the head and the neck down, from the neck down, they're going to see that physical therapist as soon as possible. We need you to move, move, move. We need to get that lymph. We need to drain the system. We need you to heal. We don't want to build up scar tissue. That's going to, again, inhibit movement and make your healing process harder. Plus, you get post-surgical neuropathy because once this tissue binds, your skin tissue binds to the underlying muscular tissue, the nervous system, you're going to close off the nervous system pathways. And I'm pointing to my chin because I'm still numb. But it closes off the nervous system pathways, and that's how we get numbness, permanent numbness, or neuropathy. Does that make sense?
Yeah, absolutely.
Yeah.
Now,
So
go ahead.
Oh, so when I just launched Orofacial Recovery Institute last year. So when I train hygienists and massage therapists and physical therapists and all these other speech and language therapists, lymphatic drainage, a lot of the times after tongue tie releases, they're like, don't move, don't move. I was like, you need to move. You need to move. If you have stitches, move gently, but you have to contract
Right.
even if it's just in and out, get that lymph down so we prevent scar tissue and the tightening up and long-term tightening up of the fascia.
Now, let's talk a little bit about the different types of movements, different types of exercises. I think like coming more from the clinician side, a lot of myofunctional therapists, at least after taking an initial course, oftentimes are like, I have all these exercises. How do I know when to give what? And it's so important that we understand the objective behind what exercise we're giving to the patient as far as
Yeah.
like, is it a isometric? Is it isotonic? Like, can you talk a little bit about like the different type categories of movement?
Yeah. So I keep it simple. I so I
Great. We all love
yeah,
simple.
keep it simple. Um so I do a lot of isotonic contraction. It's resistance training. I do resistance training, isometric, isotonics. I don't think about that stuff. All it's just so much information. The only way to strengthen muscle is either is by resistance training, whether it's calisthenics and you're just resisting your own weight, or it's weightlifting. So when I have somebody, for example, do tongue points to the left, to the right, I want them to hold the tongue point to one side, and I'm looking for fatigue. If they can hold to one side for 30 seconds without the muscle, without the tongue shaking, okay, I'm going to move on. Now go to the other side. And if they immediately start to shake or fatigue, then I know that that side is weaker. So knowing that side is weaker, I'm not going to have them point to the strong side. I'm going to have them contract to the weak side. And I'm going to have them do it by either holding or against a resistance. So I have them put their finger in front of their mouth, have them put their tongue on the side of their finger, and just resist that. So resisted range of motion. Um, and I sometimes have them take a piece of gauze, tie it around their tongue, and pull their tongue out, and then try to move their tongue back. They're resisting the movement, or they have a bite block or their finger, and they push against their finger, so they're resisting the movement forward. So when it comes to the grand scheme of myofunctional therapy exercises, the ones that I go to are resistance training, movement back and forth, in and out, and suction hold.
Mhm.
That is it. 99% of my patients who have TMJ, they can get that suction and hold up. And then once that suction and hold is up, and their tongue will naturally come on spot and it'll rest. So sometimes I give them things to help with tongue on spot, but the majority of the time,
Mhm.
it's
Mhm.
I need that tongue up. What's that tongue doing? So in cases where people have oral cancer
Mhm.
and they've had part of their tongue removed or part of their jaw removed, and they're so restricted down to the floor of their mouth, I'm going in to do scar tissue. I'm releasing that scar tissue. Most of the time they're numb, they can't feel it, and I'm stretching that fascia. And then I'm like, move. I need you to move to the other side so we maintain that stretch.
Mhm. Now, are these, so they come to see you, are these stretches that they then will be doing on their own at
Yep.
home? And then if so, is it kind of like less is more? Do it once a day, or is it multiple times a day, like just quick movements, or if you can talk a little on that.
So I want them to move 2 to 3 times a day, if not more. I've used all different kinds of tools. I've played around with tools. They have those suction cup things for sleep apnea for the tongue. So I've given those away, and I'm just like suction cup that tongue and move it. So,
Yeah.
and with people who have had oral cancer or major surgeries, if it involves their tongue, less is more.
Mhm.
I'll only give them 1 or 2 because it's absolutely
Right,
exhausting
right.
for them. And so I was like, when you're sitting in your chair watching TV,
Mhm.
just put it, here's a bag of gauze. Just sit
Yeah.
next to or when you're at the computer and just
Right.
stretch. I just need something. I just need you to move. Suction and hold if they're so restricted on the floor of their mouth. I look at it like I do at the tongue tie. I'm just working with the back of the throat to
Mhm.
help alleviate the pain in the TMJ and to
Mhm.
get some type of movement.
Now, as far as orthognathic patients go, before you had mentioned before something about 6 weeks, are you waiting 6 weeks post-op before you start seeing them, or what's like your typical protocol before you start seeing them?
So after orthognathic surgery or any type of surgery with the jaw joint surgery, um, post-operatively, I wait 6 weeks, or when the doctor says that you're allowed to start chewing, because I want them to open their jaw against resistance.
Mm-hmm.
And if they have bone grafts and plates and things like that, the doctors don't want them to put a lot of pressure. So I really advise on what the doctor says. And that's usually when they go back in for their checkup, and the doctor's like, yep, you can go and start chewing again. Um, but I do see them immediately after surgery for lymph drainage. I've actually gone in home and I do the lymphatic drainage. They're just sitting up in their chairs and I'm behind the chair, and I'm showing their family, I'm showing their caregiver, whoever's there. I'm like, this is how we want the lymph to work. I typically send them home with a care kit. They have an ice packs
Mm-hmm.
or an ice mask, kind of try to make it as much spa as possible. Give
Mm-hmm.
them ice mask, and we want compression to keep the lymph down, or kinesio tape. We
Mm-hmm.
need you to K tape. Keep that lymph down. We need you to drain. And then ice, ice, ice. Ice is your friend, because the when we're swollen, it's heat,
Mm-hmm.
and we want to cool it down.
Right.
Ice.
Makes sense.
Cold is what helps lymph dissipate. So, yes, 6 weeks. And then we can start doing some resistance. I start actually going intraoral, doing the intraoral massage, relaxing these muscles. And then I try to get them starting to open again.
And what about pre-operatively? Are you seeing them prior to surgery?
So sometimes I see them within a couple of weeks before their surgery. They find me. If I can get them in 2 months before surgery, I'd be ideal, because then I can
Right?
do
It
a
should be
full,
standard of care.
yeah, right. The patients who I've seen pre-surgically and post-surgically have, and this is just in my
Mhm.
practice, and I'm just saying biasly. In
Yeah.
my practice, the patients who have seen me pre-surgically and post-surgically, they don't have any neuropathy, and they heal quick because it's what I call better in, better out. They go into surgery better.
Mhm.
The patients who are not, I know patients are ready for surgery when I can't get their breath work down because they're in a consistent state of fight or flight.
Mhm.
And so then all I'm working on is breath work. That's all I'm doing. I can do the muscular stuff after.
Right.
But if I can't get your nervous system to calm down, I'm sending you out to some for emotional release, to craniosacral. You are not ready for surgery. The people who can't get their breath work down and calm their nervous system, it takes years. And
Mhm.
they're actually what I have found is that they're at a higher risk for infection. 9 times out of 10, they've had some type of infection because their body is fighting the trauma. Then they have massive emotional releases after. So I'm working on them, and I can't get them to move, not even months. I can't get them to move. Their jaw won't open, they won't laterally deviate. And if they do, it starts emotional release, because even though you don't remember the surgery, there is still trauma. Your body remembers.
Mhm.
And
Mhm.
so then we have to work through that. So it takes, the healing process is twice as long. So in ideal world, I would do a full myofunctional evaluation to see where they're at and just work on that, calming their nervous system down, breath work. Um, if they see me right before surgery, nowadays surgeons want them to be able to swallow before they leave the hospital because it reduces the risks for aspiration pneumonia. And so I'm teaching them to bite down, swallow. Do not move your cheeks. Do not move. It's like, I don't care what you do, but you're not going to be able to open your mouth. You need to learn how to swallow. And so I have them put a straw off to the side. I need you to suck on that straw. I need you to swallow because they will not let you leave the hospital if you can't.
Mhm.
And then I see them, yeah, immediately post-surgically. And then we just, as soon as they can get back open, then up to 30 millimeters is then I start looking at their tongue. I start looking at their tongue again to see where it's at and what it wants to do. And then that's it.
Um, so I have two questions, but let's stick with, so just so that everybody listening kind of understands what you mean by emotional release and like trapped trauma and how not dealing with those things can hinder their progress or their success
Yeah.
in their program, and talking more about like like the importance of nervous system regulation prior to having a surgery like orthognathic.
Yeah. So when it comes to trauma or no trauma, in massage therapy, we call it there's issues in the tissues.
Oh my God, I love that. That's adorable.
There's issues in the tissues. No matter our body, especially our vagus nerve, our body holds on to, we compound, we're so used to compounding
Mhm.
any type of trauma. And we just hide it. And our nervous system, our vagus nerve, all the way down to our gut, this is how myofunctional therapy and pelvic floor is related because it's one long, we hold everything here. We've got different bodies. We've got our emotional state and our physical state. And our emotional state will take the brunt of everything. If we are in a consistent state of fear or fight or flight because of some type of trauma at any point in time in our lives, and this is my massage therapy brain coming out, then our body compounds it. And then you've got the surgery where your subconscious mind is like, there's something going on here. So we're compounding, compounding, compounding. And then, it's mindset, getting into that mindset that, yes, I can heal. But even after surgery, this happened to me too, where it's like, you feel doomed.
Mhm.
You're just like, what is going on?
Right,
Because you can't move. The things that you used to be able to do, you can't do anymore.
right.
And I also send a lot of patients out for mental health
Mhm.
because you don't look the same. I don't look the same. So a lot of a lot of my patients struggle with body dysmorphia.
Mhm. That makes sense.
It's huge. I had surgery at 37 and it was, open, honest. I saw mental health because I'm just like, I don't know who I'm looking at in the mirror.
Right.
So I talk a lot about mental health in those first couple of appointments before surgery. This is what's going to happen, and I always give them options. If they're referred to me by an oral surgeon, I'm just very cautious. So, there's appliance therapy and things like that. Not everybody's a candidate for appliance therapy.
Right.
But let's go see mental health. And I've got amazing mental health providers who have also had orthognathic surgery and they get it.
Mhm. Mhm.
And so just to make sure that there's not any underlying, not just your energetic body, but your physical body is completely prepared. And in cases where orthognathic surgery, where it's elective,
Mhm.
or we're completely as prepared as much as possibly can. So
Now, how
does
do
that
you?
answer?
Yeah, no, no, totally answers my question. And I apologize if you can like low key hear my babies crying in the
No, no,
background.
I can't.
Okay. Zoom, like I feel like I've been saying this on so many episodes now. Zoom has done a really good job at blocking like background noise. Like I know you mentioned your dog before, and I remember like when I was still doing my episodes prior to having my girls, my dogs were always barking and they were always laying right with me. So like I'd hear them and everybody on the other end would be like, I don't hear them. And I'm like,
Oh,
are you
nothing. Yeah.
joking? Like they are very loud right now. But anyways, yes, you did answer my question. I guess one of the questions that I want to ask to that, because I actually just got this question, different topic. I had a question by a therapist, like when we were talking about, as hygienists, obviously there's so much we can do to assess speech. So, how it can kind of be uncomfortable when a parent doesn't realize their child has a speech issue, how to kind of broach that referral. So I guess in the same aspect, like how do you like mental health obviously is it's a vulnerable topic, very sensitive topic. How do you broach that with a patient if maybe like it's not on their radar that that's something that they really need at this point in time?
Tell them my story.
I love that.
When I started speaking, I learned through my coaches, and everybody loves a story, telling
Mhm.
your story. And so when somebody comes in, they're getting ready to have surgery. It's like, hey, so the reason that's why I built my practice. I built my practice because I had surgery, and I just want you to be aware. Now, if you are a provider who has patients who have had orthognathic who are getting ready to have surgery, and you have not had surgery, you can tell them a different story, or you can say, "Hey, so I want you to be aware of
Mhm.
you're going to go through surgery, and we don't know what is coming out on the other side. We don't know how we're going to heal. We don't know how we're going to respond. That's the scariest thing about surgery, any type of surgery, whether it's elective or not. I
Mhm.
just want you to be aware, and it's on my intake form. And have you ever seen mental health? And for what?
Right.
Um, but so broaching the subject, my patients, there's a lot of respect because I'm very blunt.
Yeah.
Um, Talk to me about this. You don't have to go into detail.
Right. Right.
It's not my space. I just want to know if this is something that you've thought about and it's into other options that might be viable for you before you go in to have surgery or after surgery. Here's a couple of names of providers if that is something that you're interested in.
Yeah.
If not, I just leave it alone.
Yeah.
My job is just to give them all the information that I possibly can so they can make an informed decision about themselves. And
Right.
I think that that's a big unfortunate, there's a drop off there when it comes to some um, talking to our patients about these things. Sometimes they'll come in just for they have TMJ pain. And I say, so I have another provider in my pocket that you might be interested in, but my job is just to give you the information. You can
Right.
do whatever it is that you want with it, but my job is to give you all the tools out on the table so you have a decision to make for yourself.
Mhm. Mhm.
And then they're a lot happier about that. They're like, "Oh, thank you for referring
There's no
me."
pressure there. It's just here's this information. You deserve to have it, and you do take what you want with it,
Yep.
essentially.
And putting it on my intake form, it already opens up that conversation.
Right. So they're not surprised that you
Yep.
are starting this.
Yeah. So if they say yes or no, it's like, oh, it says no for mental health. Have you ever seen mental health? Okay. Just so you're aware,
Right.
after surgery, there could be possibility for A, B, and C.
Right.
My job is just to give you the information and tell you what I see and tell you what I know. Whether you take it from here to there is completely up to you. I just want to give you all the tools on the table so you can make an informed decision for yourself.
I love it. Yeah,
Yeah,
no, that's a really great recommendation. I like that having it on the form so that
yeah.
it's already, it's already on their radar.
And it
Um,
makes it easier to talk about. Yeah,
right, right, because then you're not really necessarily the first. I mean, I guess technically you're still the first person
yeah,
broaching because it's on your form, but I love that.
yeah.
Let's talk a little bit about obviously social media has its pros and its cons, and things get out there and buzzwords and whatnot. And I feel like, um, I know a lot of parents now, they'll hear about vagal nerve function and vagal tone and the importance of the vagus nerve. And so let's talk a little bit about that and what are, like, if you have a I know you like simple way maybe of explaining it to patients, because obviously, like, you and I can get into it and nerd out and geek out. And, I always refer, like, my students back to Dr. Stanley Rosenberg's book, Accessing the Healing Power of the Vagus Nerve, but a simpler way to explain it to our families, and maybe even like a few simple exercises that people can do that are easy to start turning on, um, our vagus nerve.
So the the only exercise that I give for vagus nerve is a gargle in the shower.
I love
A
it.
lot of people who have vagus nerve dysfunction, they also have a high severe gag reflex. And so it also helps with gag reflex, calms down the nervous system. The vagus nerve runs from the back of the throat all the way down to our gut. And this is where a lot of women have gut intuition, right? It's that vagus nerve saying, hey, this is what's going on. There's something here. The vagus nerve, it's our main fight or flight nerve. And it's the only one, I don't want to misquote, it's the only one that runs down into the gut. So it controls a lot of our emotional state. And so, if we get that gut wrenching, oh, this something is not right, that's your vagus nerve talking to
Mm.
you. So, in order to control the breath and help reduce gag reflex and calm the body, gargle in the shower.
Mhm. And something so simple, right? And I think sometimes, I mean, I think it's just what we do as humans is we make things just way more difficult than they need to be at times.
Yeah.
But again, I think that that's a great recommendation. So everybody just start gargling out there. And I love in the shower. So I do gargling a lot with my patients, but I never think to recommend it in the shower. And I love that because I think like as a hygienist, I'm like, hey, brush your teeth in the shower. Then you don't have to
Yeah.
worry about getting smush all over the place.
Yeah. Yeah. And I like that too because you can have the water pound on your back. And
Oh,
so it creates it's a distraction. So if
yeah.
you are going to gag or if you're trying to work with your breath and you've got a distraction here, your body's able to, it's like tapping. Your body's able to calm down.
Oh, I love that.
Yeah.
Oh, that's fantastic. All
Yeah.
right. Awesome. Awesome.
I'm
Awesome.
all about getting a lot of things into one, making it simple. How do I
Yeah.
simplify this? How do I make this easier for
Right. Right.
for
And I
you?
think people totally appreciate that.
Yeah.
All right. So let's talk a little bit about uh tongue ties and I guess so my practice is not heavily based on post-orthodontic patients, but we do see a decent amount. And oftentimes I find restricted frenums in these patients more
Mhm.
often than not. So I'd love to hear your take on that. Now, of course, like we don't have to be releasing these ties if they're not causing any functional issues, but do you find that a lot of your like were you tongue tied?
No,
Okay.
no,
Do you
no.
find that there's a lot of, I mean, obviously there's just like oral dysfunction going on, but do you find a lot of restriction in the frenum? Now, of course, like working through it with movement and myofunctional therapy and whatnot. But so that's one question I have.
Mhm.
My second question is, and I think you mentioned this before, but I just want to bring it up again. Like I know for my practice, we unfortunately get the referrals oftentimes once they're already having an issue and not that, like we said, should be standard of care
Mhm.
preoperatively so that we can set them up for better success. But anyways, I typically get them when, like orthodontists can't get in there to take another scan because their range of motion is so limited. So I know you had mentioned how you work first, get them to about 30 millimeters of opening, and
Yeah.
then do your assessment. So can you talk a little bit on that?
So it's so subjective. If they're coming into a TMJ and they can't open their mouth, I need them to be able to open so I can see what their tongue wants to do.
Right.
And 30 millimeters is that's just my baseline. That's just what I've like, oh, okay, well, now I can see what's going on.
Right.
When it comes to restricted frenums, I don't always refer out for a tongue tie release. I take photos, I take videos, and then I have my table, and then in front of the table, I have a big TV.
Hmm.
And I take my phone and I airdrop, and while I'm taking pictures, they can see what I'm seeing.
Oh, cool.
Yeah. And I have them move. And I'm like, I want to see you move. I want to see you clean the back of your teeth with your tongue. And if they're like, then that's a restriction. And
Mhm.
so I don't necessarily, and I've said this in speeches, I don't like to use the word tongue tie. Um, and I call it a physical restriction. You're physically restricted. Your tongue can't do what it's supposed to do. It can't clean your teeth. And this is why, because you have really tight fascia under the tongue. If you're interested in possibly having that released, if you need a release and we can't get you moving, then this is a possibility. These are some names of some providers that I refer to release this. In the meantime, we can see what we can do with myofascial release because the tongue, it's fascia. It's fascia. And we can do myofascial release under the tongue by resistive range of motion, by
Mhm.
resistive training. The difference is, and I know I'm kind of going off on a tangent here. The difference between, I know you would ask the difference between my evaluations and that of a myofunctional therapist. It changes, it varies. It depends on what they're coming in to see me for.
Mhm.
So if they're coming in to see me for TMJ, all I'm doing is an evaluation on their TMJ, and if they can't open. And so active, passive, resistive range of motion. So active range of motion is I want you to move your head in all directions. I'm always testing the muscles in the back because if they're in pain here, it could be coming from something in the back called a trigger point. And I'm palpating, I'm massaging. So I'm like active, passive, resistive. So move your head side to side. Is there any pain there? Sometimes they're like, yes, there's pain here. I'm going to mark that down.
Mhm.
Okay, move your head up and down. Is there any pain there? Well, when I go back, there's a lot of pain here, which tells me that these muscles are what we call hypertonic. They're in a constant state of fight or flight. They're trying to keep your head forward. Okay, move your head side to side. Is there any pain there? And then, sometimes they're like, yes, no. And so I'm just marking down the areas that I know that I'm going to be treating. Then we do passive. Passive is where you move the head on your own. So I'm moving their head. I'm having them relaxed. I'm moving. Is there any pain there? No. Okay. Now let's do resistance. Move your head this way because I want to know what muscles are activating
Mhm.
where they're not supposed to be activating. And that's exactly what I do and what I teach in my workshops about the tongue. I want to know what muscles are activating. Sometimes we have patients in myofunctional therapy and they're like, I'm doing this exercise and I'm feeling it in my neck because that neck muscle is activating. So, how do we treat that? So, we can get them to do what they're just supposed to do with their tongue without that muscle activating. That one is taking over. And that's the way I look at it with the TMJ. If their tongue is moving side to side, and they're like, oh, I feel pain here because that muscle is activating. It's so used to doing that job. How do we get that muscle to stop?
Mhm.
And so I'm working on these muscles here to get them to calm down. If they can open, then I'm just looking, can you move your tongue side to side? Can you point your tongue in and out? Can you do a suction and hold?
Mhm.
That is my functional therapy evaluation. I want to know what you can't do, what you can do. So when it comes to TMJ, I'm having them active, passive, or active and resistive range of motion. Go side to side,
Mhm.
front and back, bite and open. Okay. And then you can't do that I can't do that as a provider because their jaws, they just won't let you do it. But then I do resistance. Okay. Forward, back, side, side. Any pain there. The same thing for the tongue. Side, side. Any pain there. Front and back. So active, passive sometimes, and resistive range of motion is what I do in my evaluation. I want to know what you can do. I want to know what you can't do, and I want to know what hurts. And that's it.
Now, where can existing myofunctional therapists, dental professionals, other healthcare professionals that are interested in learning more about what you do, your protocols, your assessments, all of it, how can they find you?
Orofacialrecovery.org.
And we will link that. And what about social media? Are you on social media platforms?
Yeah, so I'm on Facebook. I've connected Alamedin, which is my downtown Seattle practice, which we're closing because I'm going to focus more on teaching and palliative care.
Absolutely.
Alamedin and Oral Facial Recovery Institute have connected on Facebook. And then I'm under the niche therapist on Instagram.
All
And then
right.
I'm on LinkedIn.
We
Yeah.
will link all of these to our show notes for the listeners. Is there anything that you'd like to leave the listeners with before we wrap up?
Just keep on pushing. just keep on pushing. So, I've got so many speech therapists that are working in the hospitals that are interested in knowing, more of the manual therapy side. I'm speaking with Swedish Medical Institute in a couple of weeks to a bunch of orthopedic surgeons about the need for hygienists in hospitals, because it's so much more than teeth. It's oral mucositis, it's red light therapy, it's so much more than that. And tying hygienists into the integrative care team. So, the one thing that I hear, and it's unfortunate, and I think it's just the way that hygienists' brains are wired, is that, well, we can't do that. Well, the only thing that I want to say about that is nobody ever made changes by sitting back and saying that you couldn't do something.
Amen.
We've got to start making these changes. If I went to massage therapy school to learn these things, and the more that I learned about it, the more I'm just like, we should be doing this as hygienists.
Mhm.
So for the hygienists out there, I'm rooting for you. I'm hoping that we can make some changes. Of course, I'm not getting any younger. I am branching into nursing,
You are
because
fantastic.
because
You are fabulous.
I just want to go deeper.
Yeah.
My goal is, I'm branching into nursing because I want to know more oncology and I want to know more palliative rehabilitative care. And I want to get my name into case studies and I want to bring hygienists on board in my case studies.
Mhm.
And I'm so far ahead of it, working with the National Network of Healthcare Hygienists. We've got our online components launching in the fall, and they're medically accredited. So the National Network of Healthcare Hygienists, for any hygienist out there that is interested in having that, it's going to be 2 levels online, and then the hands-on course is a level 3, which is going to be optional. It's not going to be required. So you can learn these things and you get all your CEs. It's going to be 36 hours of online CE.
Wow.
Um,
Would you
but just
be able
so
to
we
send
can
me a
start getting.
little, like, just a little blurb or website, like just where anybody listening wanting that information can have it? Can you just send me something you think so I could link it to the
Yeah,
show? Okay.
yeah. Then yeah, the national network, the NNHH, they've already started promoting it.
Okay.
So for hygienists, I recommend taking that course because it's gonna be a little bit, it's gonna be so much more robust.
Mhm.
And I've got my 5-day workshops for speech therapists, massage therapists, occupational therapists, anybody who wants to dive into this realm. Um, I think that answers the question.
Yeah, it did.
Yeah,
Becca, thank you so much for coming on and
absolutely.
taking the time to chat with me. And we have not had a guest on the podcast talking about all it is that you do. And again, the importance of movement. And I feel like, especially we do have a big majority of myofunctional therapists listening, like we need to understand that, right? Like it is not
Yeah,
just about myofunctional therapy. There are other components to it in order for us to really see our patients get where we want them to be. So thank
absolutely.
you for your expertise and coming on. And it's been fabulous meeting you for the first
You
time.
too.